Good morning, everybody. Welcome to this second exciting day of this live webinar on Zoom on fluid dynamics for understanding aerosol transport with relevance to respiratory disorders and treatment. Obviously, a research-driven education webinar. We had a very nice first day yesterday, and we hope to continue along the same line today. This workshop is sponsored by the KTH Life Science Technology Platform. My name is Mihai Mihescu. I'm Associate Professor of Fluid Mechanics at KTH Engineering Mechanics. And together with my colleagues, Associate Professor Lisa Pral-Wittberg from the same department, KTH Engineering Mechanics, and Mario Romero from the Computer Science and Technology at KTH. We are today's hosts. So I would like to welcome first to today's keynote speakers and panelists, and as well as guests from different countries. Also from yesterday we had guests from Canada and USA. Hopefully some of them will join also the panel discussions, even so it will be very early on the East Coast in US. Warm welcome to the KTH students and faculty and staff, as well as to the general public. Founded in 1827, KTH is Sweden's largest technical research and learning institution. We have about 14,000 field students, 1/3 women, and we have about 1,800 research students and about 3,700 full-time positions. We are located in the main campus, showed very nicely in this picture here, but we have obviously several campuses in the Stockholm area, 5 campuses in the Stockholm region. With respect to the sources of income for KTH, the Royal Institute of Technology, we have about 23% governmental grants for education for the first and second level studies. We have also about 26% governmental funding for research and doctoral studies. One have to realize that the Swedish Research Council contributes with about 9% to our extramural funding, and also other governmental agencies like Vinnova, for example, Governmental Agency for Innovation, about 16.7% of the extramural funding for research. The European Union, European Commissions contribute with about 6.0%. I would like also to mention that the research focus areas of KTH, different schools at KTH departments, as part of those schools, are aligned obviously with the industrial needs as well as with today's societal challenges. So we do focus on digitalization, obviously, sustainable energy conversion, industrial transformation, life science and technology, and medicine plays an important role as well as materials and sustainable transports. We have at KTH around 50 competence centers, research competence centers, which are managed in partnership with the leading companies, industrial partners for KTH, as well as governmental institutions and other institutes. And this is those centers are playing an important role for having a multidisciplinary approach to identify solutions to today sustainable to today societal challenges. And this is, I would say, our environments where agencies, governmental agencies, research agencies, as well as energy agency, for example, or Swedish Strategic Foundation, or European Commission. Vinnova, I mentioned it already, as agency for innovation, and and European Commission through Horizon 2020, as well as Horizon Europe, now Swedish Research Council, all the centra are playing an exceptional role in actually having a proper environment for research and research-driven education. We are part, myself and my colleague Lisa Prahl-Wittberg, we are part of the KTH Engineering Mechanics Department with research on fluid mechanics and acoustics from nanoscale to mesoscales, applied fluid mechanics, flows in complex media, biofluid dynamics naturally, multi-phase flows and flows with chemical reaction, flow stability and turbulence, as well as sound and vibration. Those are among the research directions promoted in the fluid mechanics and acoustics division part of KTH Engineering Mechanics. There is also another division on the vehicle engineering and solid mechanics, which focuses from aeronautics and space industry to road and rail vehicles, to marine systems, to lightweight materials. And one have to mention that in this department, KTH Engineering Mechanics, or Teknisk Mekanik in Swedish, we have more than 200 employees today, and about half of them are researchers and doctoral students, with a total turnover around 300 million Swedish kronors, and half of this turnover, it's actually funds from external funds, external research funding from Swedish Energy Agency, European Union, as well as other governmental agencies and industry. We are part, myself and Lisa, we are part of the Applied Computational Fluid Dynamics group at KTH Engineering Mechanics. We focus on unsteady flows in complex geometries, heat transfer, thermal management, multi-phase brave modeling, as well as compressible flows and aeroacoustics, and with the obvious focus also on biofluid dynamics. And we have also research directions towards turbulence modeling, stability, and transition. We are extensively using the computational resources provided by the Swedish national infrastructure for computing, and as well as in-house and as well as commercial software programs and post-processing tools. My colleague Mario Romero, it's from the Computational Science and Technology Department at KTH, which focuses on computational and visual understanding of physical and biological phenomena, with research areas towards bioinformatics and computational molecular biology, as well as computational brain science. One have to understand that there is a lot of research efforts towards developing post-processing tools with respect to assessing data associated to computational fluid dynamics. A lot of numerical methods behind that, things related to visualization to make the invisible visible, parallel computing related research efforts towards exascale computers, as well as obvious implications related to the artificial intelligence and machine learning algorithms applied to understand complex phenomena. And yesterday we had already we went through the first day of this workshop on we covered topics like understanding aerosol transport and transmission, session chaired by Mario. We had also exciting talks with respect to the second topic targeted with respect to respiratory disorders and fluid dynamics of respiration. And today we target as a third topic for this webinar, treatment perspectives, a session which is chaired by my colleague Lisa Prahl-Wittberg. And I would like now to actually I will let Lisa also to introduce herself as a chairwoman of this session. Please, Lisa, you have the word, and you are free to introduce this topic 3, treatment perspectives.
Thank you, Mihai. I'm very happy to be sharing this session today, and I'm looking forward to this morning's presentations. So we will be having 4 presentations today, and we'll be starting off in 4 minutes with a keynote by Professor Apostolos Bosios from Department of Allergy and Respiratory Medicine at Karolinska Hospital. So I'm very happy to have you here and that you could find time to join us today. And thereafter, we'll be having a talk by Ruggero Bettini, professor in pharmaceutical technology at the University of Parma. And thereafter, Magnus Hallbäck, senior scientist at Getinge, will take over. And finalizing this session will be by a talk by Professor Laszlo Fuchs from KTH, Engineering Mechanics. So, wow, we have 3 more minutes. So Apostolos, maybe you want to just start sharing your screen and make sure that everything is working as it should.
Exactly. Morning, everybody. Good morning, everybody. It's a great pleasure for me to be here today with all of you in these tough times, and I would like to thank really all the organizers, Lisa, Mihai, Mario, for giving me this opportunity. My name is Apostolos Bosios. I'm a pulmonologist with a translational clinical science interest, and I work in Karolinska Severe Asthma Center in Huddinge. So I had the task today to discuss about airway inflammation in chronic disease. And I have thought, because as I understand the public, we are very different, to start with a broad view and go more specific and try to see what we can contribute from clinical point, what are their needs that you can help us to solve. Yeah, if we start real easy, this is our airway system, from the nose upper to the lungs. What is important to remember that we have 23 generations. So we start from the big trachea and go back down to 16, generation to generation. And here we start to exchange the oxygen. So we have all this way, and we're going to this part. And this is the reason we have our lungs here. The air is going inside, and then the blood is coming, and we get the oxygen in the tissues. This is the whole story. But the airways, they are exposed to everything. From virus, aerosols, corona, you know it. We listened very well yesterday. So they can have diseases. And when we discuss about airway diseases, asthma and COPD as the main one, and then we have something that is used to be orphan disease, but it's getting more interesting. It is the next level of them. And here what happened, overview. In the asthma, that we all know that. This is the normal airways. And this is when you get asthma. You get narrowed and there is no place for air. You know better mechanics than me. And this is pretty much the same what happened with COPD. The normal, the lumen, and here is when you have COPD. Asthma is my main research interest, together with bronchiectasis and a little less COPD. So just to get you in the mood, how you are thinking, research-wise and clinical-wise, when you're discussing about airways disease, I will go through asthma as a model, but also I will discuss about the others. So asthma is one of the main disease, the one that we call non-communicable. And it's about more than 300 million people in 2016, according HCO. And this is the asthma prevalence. We see that is between 20% in many countries, like the English talking actually. And in Sweden, we have decreased. This is a very good study from the north of Sweden from 10 years, but we have around 10%. That means that we have around 1 million Swedish people among us that have asthma. If we go to the asthma, we see that the most asthma-related death, the ultimate header say, is that in low and low middle income countries. Because most of the people think that asthma is okay. I take one puff here, one puff in the morning, no problem. But it is not so easy because there are people that they die from asthma. And importantly, if you see this one daily, that means one daily is a marker of the disease activity and the impact of the life. It is one healthy life, 1 year lost of year of healthy life. So in 2016, 25 million healthy days was lost because of asthma, 25 millions. And of course it is due to the inhalation. But it is like that, okay? But many can think that, okay, in Sweden, in USA, in Europe, it's okay, we can make it. In the people that they are in my generation can remember this movie. Do you remember this crazy roommate? She died from asthma in middle of the London, 2011. Not in some village in Syria, in Greece, I don't know, in Africa, in London. And look here, if we go, everybody can go to the social department and check the death reasons. It's open to the public. If you put asthma between 20 and 85, we see that we have every year around 150 people here in Sweden that they die from asthma. Double more women. This is another problem. And can also discuss later or in the discussion in the panel. But even if you say, okay, it's 150, what about the normal people? This is when I was in Gothenburg, when I did my postdoc and my resident there. In my group, we did a study, then we set out 30,000 questionnaire in the public by chance, and 17,000 reply. From those, we measure how many of them they have asthma, and they have asthma that they are healthy. They are like us today, not in the hospital, not in the emergency. We have signs that the asthma is uncontrolled. 14% they have symptoms every day. 9% they go to the emergency last year. 11% they have the reduced lung function. They use this rescue medication every night, and they have symptoms every night. This is the severity symptoms we use in the clinic. And 1/3 of them, the people that they are like us today, they have asthma symptoms. So there is there. And the ultimate, it costs a lot. This is a study when they done in Europe, when they take a population and they try to see at each cost, not only the medication, but also that today I'm home because I cannot work, or that my child are home, or I can come here, but I do not produce, or I have been to the hospital, everything. And you see here that in Sweden, for example, each patient with asthma is between $1,000 and $1,500. And there are some studies for Sweden as well, specifically. And here we see that we had 4 levels of asthma. The majority in total is mild and moderate, but severe also, even if they are very small, it's a huge cost. So it is there, it is a big problem. It has effect in our life daily. People die and it costs a lot. So we have to do something. And to do something, as you know, we must understand it. So let's go a little back and see what is asthma. This is the definition by GINA. This is the international organization that every year give recommendations. It is a disease by chronic airway inflammation. And I choose here because before go to asthma and other inflammation to take an overview about cells so we can understand each other. Inflammation is a normal response that hopefully we all have against something external that is hurtful for us, corona, for example. So we have two kinds of immunity. Innate immunity, this is very rapid, cannot recognize specific, but is very effective and rapid. It's like the first line. It's like the police in the street. And here we have, for example, neutrophils and eosinophils that we are going to talk a little more. And then we have adaptive immunity like T cells and B cells. Now it's very popular due to corona that produce antibody, and T cells that they remember. This is like the office. And this is low, but T cells and B cells, hopefully they live forever. T and B cells are the cells that we stimulate with vaccine. So they recognize the enemy forever. And these T cells, they are the drivers, they are the head. And because we're going to talk, there are a lot of cells, T cells. One of them is like T helper, is the one that drive the process. And they have a lot of names, but mainly I got you to remember there is this Th1, that is the normal one that we have against bacteria. Then is Th2, that is the confused one. When we think, I believe, for example, my T cells believe that birds is very, very, very dangerous because I haven't seen that in Greece I'm coming from. So when I come here now, my immune system got confused and thinks that birds is something very extremely difficult and dangerous. So start to reply to that. And this is my Th2 cells that do that. But hopefully when I get corona, I get Th1 response. And then also Th17, and there are many more. If we go to the innate cells that do the job, this is the soldiers, they are there. The other are the officers back. We have eosinophils. Eosinophils, we have them many, many years, and we think that their work mainly was to kill parasites. They are small cells, but they are very effective. So they have all these small bubbles with enzymes. So when they get a parasite, coenzyme, they stack and they release enzymes to kill them. And they can do it several ways. They have many functions as well, but this is the main one. Now we find more and more. And this is good as long as it is as much as needed. If it's too much, then you get a problem. Then you get neutrophils, the one that we know when we get infection and we get our blood diff and everything. White cells, what you call them. And their job is that they produce massively. If I get an infection, they come up in hours and they go there to kill the enemy. So they go through the blood, they go to the tissue, and they have several ways. They eat it, they catch it with a net, and they produce oxygen species. So they are toxic as well, and they die. Eosinophils and neutrophils, they not live forever. T cells and B cells, there are cells that exist through our life, not all of them. So this is an overview of the immune cells. If we go back to the asthma, we know now that it's not one disease. And this is one that we should think for all the disease when we are doing now our planning and investigation for new medicines. This is the time we are living now, precision medicine, personalized medicine. So if we go that asthma, we have asthma apostolos that start to be allergic like a child. Then we have Mario, that get asthma when he was like 35. And then we have Mihai, that he liked to smoke, and he get asthma due to that. Is Lisa, Mario, and Mihai get the same medicine? It used to be like that. Hopefully you are changing that, and perhaps you can help a little to change that a little more. No, because now we understand they do not have the same inflammation. When you have the allergic classical asthma, the one that we recognize more, that perhaps a lot of our children have it, is that it came, for me, for example, it came birds that I have not recognized earlier. The birds go to my immune cells, pick it up, and they present it. What are you going to do with that? Normally, Mario will say, it's nothing. But my cells, they get a little confused, so they think that is really something dangerous. So they present it to the T cells and they present it to the B cells to make antibodies against that. And this is the allergic antibodies, IgE. So every time that this come again, I have a reaction. My body set an alarm. So I produce antibodies that this one that make the problem. And then we have the other that they come later in life. And it's like, okay, because I must stop smoking. And then you have also bacteria. And here you have neutrophils. These two, we used to treat the same way. This is much easy because they respond to steroids. This one is the one that we do have a problem. We don't have too much to do it. Oops. So now I would like to present a little fun. I have mixed here data from research, but also from patient. So this is studies from my postdoc when I came from Greece. And this is the classical allergic model. We take mice and we make them allergic to protein from egg of albumin. So we make them allergic and then we give them the allergen. And then you see in the lung. And you see here, in these mice, we give thymidine analog, BRDU. So every time the DNA is multiplied, we can detect it. And you see here in the airways, the cells are the eosinophils. And then you can detect it with immunofluometry. And you see here that this is brown. So this one is totally new that have produced during the exacerbation. And this is the mechanism. Every time you get the allergen, I produce eosinophils from my bone marrow and they go to the lung. And here data from postdoc and PhD I had that we see that there are a lot of cells inflammation in the airways, in the mice, and around 40% are eosinophils. And here with flow cytometry, you can see that there are large cells, granulocytes, and they express different markers, mature but also immature. So we have a continuous production of eosinophils. But Lisa likes people. She doesn't like mice. What about people? That's true. Here, there another study we have done that to take people again from these people that they have stable asthma, and you look in the blood eosinophils that they are normal. They are normal eosinophil levels. But in the airways, normal is between 500. So take the one that they have low and high, but within normal range. And the one that they have upper height in the blood, they have up to 6-8% in the airways. They're supposed to have below 2%. And this is to show that eosinophils and inflammation are in the tissue. And you have to go there. It's not easy. And they have also continuous production. But this is the classical model, very nice, but we had a problem. What happened with Mario that he has a response when he go out and it is -10. He's not allergic, but he get a little very good response, sorry, my daughter was very active in the night, that he got a really allergic response when he go out in -10. We didn't have a response for that until about 80 years ago, we found another cell, the innate lymphoid cell. This is one of the hot immunology issue. There are like T cells that they can act like T cells, but not specific and very quickly. And we have found that they are the same subtypes, 1, 2, and 3. So what is the current inflammation model is that we have type 2 high and type 2 low. And we have type 2, the inflammation that can be from the allergen. And here can be also from bacteria. But then we can have also that from pollutants, smoking, cult, affect our airways. And the airways, the epithelium, produce specific markers that they call alarmin, that they give a signal to these cells that there are very few. In the blood, we have like 0002. In the airways, there are 0005. And these cells, they produce the same like these memory cells, and you have the same effect. And if this happens again and again and again, we get again the inflammation here, both. We get a lot of these cells, eosinophils, again and again. After some years, we have something called remodeling. That due to the excessive inflammation, there are signals to the smooth muscle cells that they become thick. And here what we got. This is biopsies from a normal airway and from patients with asthma. There are patients that they have died in car accidents. Here, Lisa, she has a very nice airway epithelium. She has a little muscle and she is happy. Myself, that I have asthma and I have not take my medicine, I have this one that is very thick mucus and inflammation, or that. And I have a very, very thick airway. So I'm stuck. This is the chronic airway obstruction. This one does not open. It's very difficult the medicine to come here because they stuck here the medicine, but also it's very difficult even if the medicine go to open. And this is from patient that we have. I meet patients with severe asthma and patients with bronchiectasis and infection mostly, but also the other. Here is a computer tomography. We heard a little yesterday from Fluida, sorry. Just for the one that they are not familiar, air is black, like that. All the other are white and gray. So white is the skeleton, and then muscle, a little fat, and then everything that is like mucus, cells, fluid, they take white or gray. And this is what we see going to do. And you see here, the airways normal must be like that. This is a normal, this one. This one is open and thick. There is inflammation. And here as well, normal is this one, and this one, and very smaller. Look, this one. There is inflammation in the big. But also importantly, there is the one that we call small airways inflammation. This patient, you see the big airways, it's not a problem. But if you look carefully, the parenchyma, this is more black, and this is a little gray. This is due to the small airway inflammation, to this one that we discussed in the beginning, that they are very small. They close. Because the big one, okay, they are inflamed, but they are open. There is place. The small one is like small roads. If one car stop, the traffic stop. So they stop and they cannot go through. And this is affect also the inhaled medication. And we must consider when we do inhalation route. And this is not easy because like Fluida told yesterday, I have heard a little, not all, unfortunately, due to the clinical duties. The classical we have now, the lung function, is talking about the big one. The small one, it's a little, now we have to pay attention. It's not easy to fight them. What we do? Okay, there is inflammation. Is it important? Look here. This is from the, again, it's WHO, and you see the mortality. And you see here from the 60, the mortality goes down and start to go down from this year. And from medication, this is the time that we just 5 minutes that open the airways. That is very important. But here they start this inhaled steroids after the 80s. And we start treating the inflammation. And this is where we are now. Just an overview. In the asthma, we go step by step. We start from a simple one, and then do we need more that we have symptoms and the patient does not feel right and we have inflammation, or step up. And all that you see here, low dose inhaled steroids, low dose, medium dose, high dose. So every time we go up. And until 3 years ago, 4, this is what we got. And by the end of the day, we have steroids, oral steroids, that is not good for the body. But now, for the last 4 years, we have biologic. So we have, this is an overview of inflammation. It's a mess, I know, but I just want to point out now that we have biologic antibodies that they block specific inflammation pathways. And the patients are feeling well. We have this IL-5 and IL-4, IL-13. And this is working very nicely. It has made a revolution. But I have met a patient the other day that he was so good that he stopped getting his own medication, the classical one. It didn't work. So even if we have been there, the main medication that make the difference is the inhalation one. And it's very important that we get the best level before and then that we keep it. So even if we go to the next level of medication, we still need the inhalation route. But we pay a price. And this is that if it is too much, some of us is getting a pneumonia. And this is in asthma, but it's also a big debate in COPD. Because COPD, it's different. It's meant with air polluted. It's smoking, of course, but we should not forget that there are people with biomass, and 15% of people that they have COPD, they have never smoked. But it's like 5% of all deaths globally in 2015. And this is the inflammation, the marker. Don't look at that. Look here. Neutrophil is the cell that is driving that. But it's not only the inflammation that make the problem. The problem is also that the lungs, they are a very big ecosystem. When I started studying medicine, I have studied or teach that, okay, the lungs, they are sterile. That's a lie. We have a jungle down there, the microbiome. And when you smoke, then we affect it. Normally, what we know today is that we get all the time bacteria, and then we take out bacteria by cough and mucus and immunity. And when we have a balance, like Lisa today, we have an FBOsis. Her lungs are very happy. But my lungs, if I get now to get a lot of bacteria, then I stimulate all the innate immunity cells, all the we discuss, and then I get a continued inflammation. And with smoking, for example, it's getting worse and worse, and it's a mess. Here, it's a very beautiful experiment, or they get the lungs for the people that they have COPD at that stage that they need to do transplantation, lung transplantation. And they look, you can see here how is the lung. It doesn't work. And they look the different bacteria. And they have all the kind of bacteria that all this one, they are mean bacteria that's supposed not to be there. These people, they did not have a pneumonia, they have a severe COPD, and they are colonized with bacteria, Pseudomonas, remember that, Haemophilus, and many others. And what happened that also affect our medication? When when Mario is getting an infection this weekend, he will start to cough and have some mucus. Why? We take here an experiment, very nice, that they take cells and they infect it with pneumoniae, the classical reason for bacteria, for pneumonia. And they produce massive mucus protein, this MUC5B and MUC5A. And you can see here, this is the cells, you understand them, classical method immunocytochemistry, confocal, and then with DAPI, the nucleus, here we stain the protein, and then we put them together. And you can see that there are a lot of cells that produce it. And this is the case. Normal, Lisa, again, that she's healthy, she produced today, she will produce about 40 to 50 ml mucus, and she will not understand. It's all the time. And we just solve it. But myself with asthma, I will have much more. Mihai that have COPD, much more. And then if we get to this is not our case today, but cystic fibrosis, that they have a main problem, it's much more. And all that, what we get, bacteria. And then we start to have dysbiosis because when you have excessive mucus, bacteria stuck there and they start to interact. They are isolated, they make their own countries. And it's very, very, very difficult to take them away. And when we have this all the time, that we smoke, we have asthma, we have mucus, we have bacteria, dysbiosis, then you can have in all chronic disease, like we discussed, asthma, COPD, but also bronchiectasis. What is bronchiectasis? It's this one. This is our normal lung. Bronchiectasis is when there is the destruction of the lung to that level that we make big airways. And then we have extensive mucus there. And bacteria love it. It's their home. They find food, they find shelter, they're happy. And how they start? They start with infection, inflammation. We cannot take out the mucus. We take more mucus. We have microbia that stay there, colonization, and then we have destruction. And then start again. And neutrophils are the cells that drive that as well. This is one of our patients. You see here, this one big, how big they are. This is the normal. And here is with bronchiectasis. You see they are big. And there is this infection here. This is a good bronchiectasis. We have patients that they are much, much, much worse. And what is really a problem is colonization. This bacteria, for example, Pseudomonas, they have this cycle that they produce the spores, and usually they take antibiotica, they are away. But then they put mucus and they are inside, so they are protected. And then they do that again and again. And if you get that, we cannot take it away. People come here, get antibiotic in the blood, double antibiotics, 2 weeks, very, very high dose, and we do not succeed. So what we have done, people try from cystic fibrosis to get antibiotic in the lung. And here also inhalation that play a role. And if you take this that we do in medicine systemic review, means that we take all the studies and put them together to have a lot of patients, because I have 10, Lisa have 50, Mario have another 10. And then we put here 0. And then this way, it's like, okay, favor the control that the medication does not work. This way it works. And you see here that it's working. But not extremely well. We get less bacteria, but the patient, they are not healthy. What is new there? We try, this is the goal now, try to increase the concentration, that the medication should go inside. So they start to get liposomes in some of them to go there, hear the airways, and stay there. This is a very nice model because we have the mucus. This is the cell airways. You see that mucus. So we must find a way, mechanical, and to deliver that in the way that they can go high concentration to the place that we have the problem. Is it only that? No, lungs actually can be much more. This is just a nice story that they have actually made inhaled insulin. 2010 was a big thing. 2014 was established in USA, many billions. 2016, take it away. Because they say there were changes in pulmonary lung function that affect absorption of the drug, and that the patient was unstable with lung disease. So they cannot control how much insulin Lisa will take. And this is the problem with the inhalation medicine. We cannot easily control where the medicine will go and what they're going to do. So to finish, because I have talked a lot, just to overview, airway inflammation characterizes airway disease. And this is not weird because our lungs, they get exposed so much. One, we have now the key the main medication is the inhalation steroids, and the other that they open the lungs. This will remain no matter the next level. We have problem to deliver in the right way, to deliver where is the problem. Now I take the one medication and I'm not knowing if it goes here, here is the inflammation, perhaps goes here. So we need to deliver more specifically. And also we need to do less because it is this one. We cannot deliver to the right place. We deliver much more. We get side effects, and we need also the next level to use this for antibiotics. And with that, this is the place when I'm working in the center of Sweden, and I'm happy to take some questions. Thank you.
Thank you so much. Very interesting. We got a question here for you. Since airways are partially blocked in asthma, how does the steroids get to the right place where it should act to reduce inflammation?
It does not. We have a problem there.
Yeah.
So this is one problem. It is the classical inhalation. There are this pulver, and there is spray. Mm-hmm. And what we do now, if it is this small airway that you say block, they cannot go there. So we have patients that they have this cycle that we open the steroids all the time, but they do not go to the right place. They have been steroids now that they are small particles, 2 micrometer. The classical one is 5 micrometer. And we use like this inhalation that we make, we vaporize them, so they are smaller to go inside. By the end of the day, we are many times obliged to give systemic steroids. So if we leave it to be very, very big problem, we have very difficulties to get there. So that is important to start early. But even there, this is a big problem.
Okay, and then is some follow-up questions. Could NO be helpful in relaxing smooth muscles? NO,
yes, it's working, and they do that, and you use it as a marker. Okay. There is this exhale NO, fraction exhale NO, that the smooth muscle produce it, but they work it to a degree. So from one point of view, it's trying, produce, but it's so obstructed that cannot do the job.
Okay.
And what happened here that they continue to produce, and then we take them out and use it. There are markers, LR machines that we measure that.
All right. And is there antibiotic hydrophobe so that you use lipoproteins?
The classical antibiotics that we use now, they are, if I don't know now, you know, you are getting now a little too deep for me. The one that we use now, they are soluble in the water. But the problem in power as well. The problem is that as it is, they affect the lungs, because our lungs are inflamed and there are particles. About 30% of the patient to 50%, they respond with cough. It's irritating. So we get a lower dose and you cannot go increase because the patient cannot accept it. So they think that with liposomes, they can get less dose, but more effective.
Okay. And then another question here is, how does this chronic airway disease affect patients affected with viral infections in the airway, such as COVID?
General, this is something that we are learning. General, patients with asthma and COPD, they get a very serious, they get viral infection and they get an asthma or COPD exacerbation. They're getting worse. And usually, sorry, Lisa, you are my research person now.
Yes,
if Lisa she's healthy, she gets a normal virus infection, and he will go away in 3-4 days. Myself, the virus love me, rhinovirus, that the most, so they will stay for 3-4 weeks. If the asthma is well controlled, they stay less. With COVID now, we thought that it would be like that, so we're terrified about people with asthma. But hopefully, if this is not the case, when they come the big studies, data from China, but also from USA and Italy, we saw that patients with asthma was not among the most severe one. And then we start to look, and we found that ECS, steroids, that regulate the receptor AC2 that COVID used to go inside the cells. So actually they are protected.
Okay.
And they have done that. They found, they take out biopsies from people that they have asthma, and they take steroids and they see that they have less expression, and then they take cells and expose them to steroids and they measure the receptor. So it seems that it's protective, not to have asthma, to take steroids. And this is something that we see in the clinical as well. This dexamethasone that they're working, they're discussing, it's steroids in the oral use.
Okay, yeah. And then I think one final question here for you. Is there a way to monitor or estimate drug concentration in lungs of patients with limited breathing capabilities?
Again, sorry, Lisa, I missed.
Is there a way to monitor or estimate drug concentration in lungs of patients with limited breathing capabilities?
The classical studies that they have done, because it's, I haven't go there, but if you take this classical, it's only 30% that they go to the lung. They use this with, I know my mind now. With they put in phosphorus, and they put in the nucleotide, and they use in camera, in gamma camera. Okay. So they look like that, PET-CT. But this is the class. They knew now that they are working. They do this computeral artificial intelligence model that they can see how it works. So they do a 3D, you know that better than me, hopefully, I believe, that they put, and this is something that they put the lungs, they make the model, computer model, and then they have that as a model with 3D, and they can see how it's working. This is, I think, is something that people would like to do. They are working, because it can be better, that we will not need patient to do models. We can do in the computational model. This is the future. Okay. So I believe in 10 years, hopefully, or 15, that if you come to me, I can scan you and see how is your lungs, or get in CT, this like fluida, and then I can make the medicine that will go directly where is the problem. Yeah. This is the wow, the dream.
Okay, thank you. So, let's hope we get there sooner then.
Yeah,
thank
hopefully.
Thank you so much for an interesting talk.
Thank you yourself.
And now we're going to head over to the next presentation, Professor Ruggero Bettini from University of Parma.
Sorry, I stopped sharing.
Yes. And Ruggero. The floor is yours.
Yeah, can you hear me?
Yes, we hear you.
Yes.
Okay, can you see my desktop?
Yes.
Okay, good morning, everyone. First of all, I'd like to thank you for the invitation. I actually have to say that I enjoyed very much the yesterday presentation, and also today I think it will be very interesting, and Apostolos paved the way for my presentation, and I think I can make some more detail with respect to the medication and to the treatment related to the aerosol therapy. Okay, so there are many products that may be administered directly into the lung by aerosols. Apostolos already mentioned powders, spray, and other things. Today I will focus mainly on nebulizer because I think that's the main focus of this webinar. So nebulizer are mainly solution, or in some cases they are suspension that are aerosolized by means of some specific device that are air-jet typically, or ultrasound system. In some cases we may use also pumps system. Apostolos already presented the Weibull model for the different generation that describes the bifurcation in the lung. This is obviously some typical, how to say, and standard description of the anatomy of the human respiratory tree. But in general, we can distinguish between the conductive area and the respiratory area where the gas exchange takes place. And what I would like to stress here is the system of the bifurcation. I come back on this in a moment. The lung has some specific features that we have to take into consideration while using this way for administering drug and for treating, obviously, at the first attempt, local diseases, but also, Apostolos already mentioned also insulin, but also for treating systemic diseases. These specific features are indicated here on the right-hand side of the slide. We have to consider one main thing, the fact that the respiratory tree is a filter. Our respiratory tree has not been designed for getting medication. It has been designed for avoiding the pollution, the powder that are outside, and then, of course, the microorganism to enter into the lung. So it is quite an efficient aerodynamic filter. And in this respect, we have to consider that the powder or the droplets that we would like to deposit into the respiratory tree would have an hard time to get efficiently into the lung. The lung has also quite a good immunocompetence, and in terms of usability, let's say, we have to consider about 1 square meter per body weight. Some people say that the lung is a huge surface for drug administration. It has the surface of a tennis court. I think it's a little bit overestimated. It depends upon, of course, on the size of the body. 1 square meter for kilogram body weight is something that's quite, I think, close to the reality. Especially in the lower part, we have a very good eye vascularization and permeability, which is of course related to the gas exchange function of the lung. But it may be exploited for obtaining a good absorption of the drug due to the very thin epithelium especially in the alveoli and alveolar duct region. One other point that I would like to stress is the fact that the dimension of the tube of this pipeline decreases as we go down. And of course, this is also something that we have to consider with respect to the dimension of the particle or droplets when we would like to deposit this particle or droplets into the lung. The deposition is, no, sorry, I escaped one. One point that another point that we have to take into consideration is the biopharmaceutical, which is part of my topic of today. This is a very simple, let's say, PK and biopharmaceutical model that describes the fate of the drug once it is deposited in the deep lung or in the tracheobronchial region. Sometimes if it is deposited here, you have very low absorption. I think that yesterday during at the end, the Dr. Broman presentation, there was a question concerning the PK of the fate of the drug in the blood after lung administration. And well, if you have a deposition in the tracheobronchial, it is less likely that you have a blood absorption, whereas you have a massive or very large drug absorption when the drug is deposited in the deep lung because of the thin epithelium and the very high vascularization. One other aspect that we have to consider with respect to this biopharmaceutical, let's say, model is the fact that this model depends upon the type of drug that you have. In particular, if we would like to make a parallelism between the biopharmaceutical classification system that has been developed for the oral route and the possible biopharmaceutical classification system for the lung administration, of course, we have to consider, first of all, the solubility. There was a question for Apostolos a few minutes ago on the solubility of the drug and therefore the dissolution rate. And this is particularly important in the case of aerosol, in which we have suspension, so solid particles that are transported by the droplets of the aerosol. The permeation is related to the lipophilicity or hydrophilicity, on the other hand, of the active ingredient. The stability in the environment, which is not only a chemical stability, but also physical stability. Imagine that we are dealing with droplets, and the stability of these droplets has also to do with the capability of this droplet to keep the same dimension all over the lung where they are traveling. And so there will not be coalescence with increase of the droplet or reduction due to some evaporation. And then other things are the fact that we can avoid the first pass effect. Transit time is not very important. What it is very, very important is the deposition. Deposition is not present when we deal with oral administration. When we deal with oral administration, we have to talk about transit time. The deposition is the key factor and the key parameter in the lung administration. The deposition in the lung administration has to do with two main aspects. An aerodynamic aspect, which is related to the bifurcation system and the transport in the tube, and the biopharmaceutical aspect that has to do with the interaction with the mucosa. The mucosa is not a simple let's say, even surface. It's a surface covered by mucus, and we have presence of cilia, which interact with the formulation, and the interaction depends upon the composition of the formulation, and of course on the dimension of the particle. And the dimension of the particle very much affects the deposition mechanism. We may consider 5 main deposition mechanisms, at least in general terms, in theory. One is related to the electrostatic interaction with the wall of the tube. Other is the interception. Then we have impaction, and settling and diffusion. All these are theoretical because we have to do with a real body and quite a large anatomical variability due in particular in the case of diseases, plastic remodeling that yesterday we already seen with Jan de Backer presentation, and today Apostolos very well pointed out. We have to consider also the fact that the patient makes some maneuver that may be correct or incorrect for the administration of the drug. We have to consider the aerodynamic part, the aerodynamic diameter, and the particle velocity. The dimension, so the aerodynamic diameter, is probably the most important parameter that we have to consider. And we may have the inertial impact on the sedimentation and the diffusion. And according to the dimension of the particle, the deposition may occur in the upper airways, in the middle, or in the alveolar region. One very important point that has to be considered is the dose, a very important aspect from the biopharmaceutical point of view. And this very important aspect, I think, has been also touched yesterday. There was a question still for the Dr. Broman presentation. The dose is a key element. For the lung, we don't have to deal only with the label dose, which is the one that will matter, for instance, in the ampoule or in a capsule, if we are dealing with a powder. But we have to deal also with the dose, which is the liver device, so the amount of dose that exit the device, and also the fine particle dose, so the actual fraction of the dose that reaches the lung, so reaches the action, the site of action. The determination of these doses is very important. So we have some, thank God, we have some very well established method for determining the amount of drug that can be delivered by an aerosol device. And this is some picture. We have some guideline for this, and we may follow this guideline. And to establish the amount of dose that reaches the deep lung, we usually employ some impactors. Yesterday, Etienne Robert already presented some study with its own impactor. We usually take the pharmacopoeial impactor. So we exploit the fact that this impactor has already been well established, and in particular with respect to the airflow that has to be used. In the case of nebulizer, the airflow should be set at 15 liters per minute, which is some standard aspect that we apply, but we need to consider that the patient are not a mechanical pump, are not a suction mechanical pump. Those are the inspiratory profile of asthmatic patient that we recall some years ago. And you may see, sorry, that the difference in terms of peak and velocity and wall inspiration capability may be extremely different among the patient population. So we use these impactors, such as the Anderson cascade impactor that has 7 stages, and according to the flow that you use, you collect in the different stages particle or droplets having different dimension. Another one is the next generation impactor, and the system is almost the same, works in the same manner. And what we do with this impactor, we determine the medium mass aerodynamic diameter. So we determine the amount of droplets of particle that goes in the deeper part of the impactor, and geometric standard deviation. Those are determined when we plot the data in a log probe with representation like this one, and the medium mass aerodynamic diameter is the 50% of the distribution, of course. Other parameter that we may determine is the fine particle dose, so the amount of the dose that reaches the deep lung, and the fine particle fraction, which is the ratio between the dose that reaches the deep lung and the total amount of drug that has been delivered. When dealing with solution or suspension, we don't have a simple drug dissolved in water, but we have other components. So we play with different formulation that may have quite large variability in terms of concentration of the active ingredient, surface tension of the droplets that we generate, and viscosity. And these parameters are very much affected by the components of the formulation. So we may play a lot with this parameter that may be used and exploited in a positive manner, or may be also detrimental for the efficient deposition of the formulation in the lung. This is an example of a paper published a couple of years ago by my group for the administration of coenzyme Q10 in 3 different formulations. I don't have time to go very much into detail, but we nebulize with the same nebulizer and we deliver the same, more or less at the same rate. And as you may say from the data here, the dose delivered and the median mass aerodynamic diameter, as well as the respirable fraction, we got quite a big differences in terms of deposition and aerosolization behavior and aerosolization efficiency by simply modifying the composition of the formulation. The other player is the nebulizer, so the equipment that we use for making the aerosol. There are, I think, a huge amount of different nebulizers on the market. They are more or less efficient. I don't want to go too much into details here. What I can say is that the nebulizer requires a set of different parameters. You have a list here of different parameters. Probably one of the most important is the nebulization time. And you may see here with 3 different nebulizers how the nebulization time may affect the fine particle fraction. In some cases, you have quite a good linear relationship between the aerosolization time and the fine particle fraction. In some other cases, these are irrelevant, so the system works in the same manner independently on the aerosolization time. Again, for the nebulizer, this is an example of nebulization of cholestymetate, so an antibiotic for the treatment of lung infection, with different nebulizers. I'm not talking about the different nebulizer, but there was different nebulizer with different volume and different therefore doses. Again, I don't want to comment too much in detail. What you can see is the huge difference in terms of delivered dose and respirable dose that you may have according to the nebulizer that you use. Those are experiments that have been made in vitro. In vivo, those experiments may have also quite a huge, how to say, counterpart. This is quite an old paper that clearly demonstrates that when you administer an antibiotic by intravenous injection, you may have quite a large serum concentration, but very low concentration in the sputum, so in the place where you have the infection in the lung. Whereas the concentration in the sputum can be increased in a huge manner with the proper formulation and the proper device. So in conclusion, I take quite a lot of time. I'm sorry for being a bit longer. What I can say is that we are dealing with a toy which allow us to play very much. The clinical outcome, I don't know if Apostolos agrees with me, it's a very complicated function of different parts. We have the effect of the formulation, we have the effect of the device, we have, first of all, the effect of the patient variability. That's why it's very difficult to develop a product for inhalation. And if we talk about products that are nebulized in liquid form, we have to take also into consideration the environment, because the environmental condition may change may change the dimension of the droplets and their velocity and so on. Thank you for your attention.
Thank you so much. We have time for, we take time for one question now. So we have one here that's, do the impactor studies carried out at some specific humidity and temperature?
Well,
And what is known about the dependence on particle sizes on these parameters?
Yeah. Definitely you have to monitor the condition, the environmental condition, and basically it is recommended to work in standard conditions, so 20 degrees Celsius and not less than 65% relative humidity. So you need to if you want to make a comparison between the different formulations. Otherwise, this may be affected by the rapid evaporation of the very small droplets. The bigger droplets are not very much affected. The small droplets, of course, they have a very high surface area and the evaporation takes place very, very rapidly.
Yes. And one more here, because I got one from Apostolos. Have you in mind any correlation between patient lung function and choice of nebulizator?
Well, there are guidelines for that. I'm not a physician. I know that there are guidelines. You may select the proper device according to the patient lung function. Of course, nowadays we are very much shifting toward powders because they are more stable, they are easy. You can make a lot of formulation changes, but of course you need that the patient will be able to extract the powder dose from the device, which is not always the case for if you have patients with severe diseases. And so you shift toward the device, aerosol device and they must be very efficient. What you need is the fact that they should be able to produce as much as possible extra fine droplets. So extra fine droplets are those that have a diameter lower than 2 micrometers. I don't want to say aerodynamic diameter because in the case of droplets, the aerodynamic diameter coincide with the geometrical diameter.
Yeah, and as you said, we have a very fine or very effective aerodynamical filter that we need to cool somehow. And we have individual variations.
Lisa, you have to overcome the physiological defense barrier. And that's why.
Yeah. Thank you so much for your talk. And now we're heading over to ventilators. And I would like to invite Senior Scientist Magnus Hallbäck.
Yes, hello.
Welcome.
Thank you. I try to share my screen.
Yes.
I will share.
In the bottom there, you should see share screen there.
Yes, share screen. I pressed that one.
And
is something happening?
then you should see your PowerPoint maybe, or your presentation coming up.
I should have a choice which screen I would like to share.
Or if you have the presentation up, you should be able to just press it and then it.
Okay, because really, I think I have to do it again. It's really strange now. It looks awful right now on my screen here. Something odd. I tried this in the morning, but now it looks very strange.
What do you see when you press the share screen one?
The only thing that happens is that I get I have three screens here to choose between. So I have my, and they appear as having a number 1, 2, and 3, but I cannot choose anywhere to share screen 2, which I want to share. I don't know. Okay, now it's here. It was behind the window behind. Okay, so I hope it works better now, perhaps. And if I start presentation mode.
There you go. Seems like.
Can you see something?
Yes, I see blue with geting on it.
Okay, that's a good start, but now perhaps you see.
Yeah, and now I see challenges in mechanical ventilation.
Yeah, excellent. That's good. Okay.
So, floor is yours.
Yeah, thank you. So this talk will be a little bit different from the others because I'm not going to specialize on the aerosols, but I hope it fits in somehow anyway, because it's about treating sick patients anyway, in this case with ventilators. And that contains some fluid mechanics as well. So a few words about geting. I don't know if you have heard about it. It's a Swedish group with about 10,000 employees, 800 involved in research and development. In Solna, where I come from, we are about 400 employees, and 100 of us work with R&D. And there are production and development sites in several places around the world, mainly in Europe. And also we have sales and service in many regions so that we can reach about, or more than 130 countries with our products. A brief introduction. So the products serve different application areas. Intensive care, where we have the ventilators, and operating rooms, and these are the ones that I will talk about. And we have other application areas as well. I won't mention them here. Intensive care, then, it contains both therapeutic devices such as ventilators, but also monitoring and other systems. And ventilation, we address both ICU and neonatal ICU there. Can you see my point, by the way?
I don't see a pointer.
How do I get the pointer visible? Anyway, maybe it doesn't matter. And we also have extracorporeal life support, which is also related to ventilation. And in the operating room, we have a number of different products, operating tables, lights, and anesthesia machines, which is the thing that I'm going to mention something about, which involves fluid mechanics as well in different medical gases. So the products that I'm going to mention about here is the ventilator mainly. The ICU ventilator, it's known as the Servo family with different versions of it, ISUN. We have the devices for NO delivery, inhaled NO delivery. We have the extracorporeal life support, where you have to, well, when the lung doesn't work as well as it should, sometimes you need to go to extracorporeal ventilation and circulation. And then we have the anesthesia machine. They are known as the Flow family with different versions of it. Where you can administer liver anesthetic gases as well. So it's a combination of a ventilator and a device for supplying anesthetic gases to the patient. So challenges of ventilator treatment in the ICU. So the goal for the clinician is to provide adequate ventilation to a patient without inflicting more injury to the lung, and to get the patient out of the ventilator. And that's known as weaning from the ventilator. So in order to do that, to do the first, to avoid ventilator-induced lung injury, really, you have to use low tidal volumes to avoid excessive stress and strain of the lung. A sick lung is normally heterogeneous, so a tidal volume of 500 milliliters, for example, which is nothing really in a, it's not a challenge for a healthy lung. It can be really tough and cause a lot of stress and strain in an injured lung, because 500 milliliters only reaches perhaps a third of the lung, and that portion will be a lot more strained and stressed. So low tidal volumes, and also you want to be able to fine-tune how much support to give the patient, because if you give too little, the diaphragm, the breathing muscle, will be experience fatigue, or if you give too much, if you get problems with atrophy, the muscle gets weak very quickly. The weaning process will be tougher. And most important, perhaps, most acutely important, is to ensure adequate gas exchange. You want to optimize how ventilation and perfusion meets or matches each other in the lung. Not a problem in a healthy lung, but in an injured lung it's a problem. Reduced dead space and interpulmonary shunt, which are aspects of the VQ problem. If you have a problem with oxygenation, you can start by increasing the oxygen fraction in inspired gases from normal 21% to up to 100%. But you cannot do the same with CO2, because you inhale fresh gas with no CO2 in it, but you cannot really administer gas with negative CO2. You can't. There is no knob to turn there. So then you have to play around with other ventilation parameters in the best way. If it doesn't work, you have to go to alternatives to the conventional tidal ventilation, which could be high frequency oscillation, completely different, very small tidal or volumes. It's just a vibration which increases the diffusion instead in the lung, or the extracorporeal solution where you assist from outside. It has a number of different names, starting with extracorporeal, membrane oxygenation, lung assist, life support, or CO2 removal. And what can the ventilator, or how should it be designed to support the clinician in the best way? Well, a good ventilator facilitates interaction between the clinician, ventilator, and the patient. So it should be safe, of course, easy to use, and you should have a flexibility of therapies there. So you should be able to switch between control or support modes, invasive, non-invasive ventilation, HFO, for example, high frequency oscillation, and to fine-tune the various parameters. It should be adaptable with the patient. It should be sensible to patient needs, triggering. It should be delivering gas in synchrony with the patient, and preferably in proportion to the need of the patient. And you should have accurate monitoring as well. You should monitor flow, pressure, and gas exchange, and even EDI, which is a special feature of our ventilators. It's the ventilator picks up a signal from the diaphragm muscle, and then delivers gas in timing and synchrony and proportion to the patient need. So the patient brain gives a signal down to the diaphragm, and then you listen to the electric activity of the muscle itself. And based on that signal, the machine can deliver in proportion to what the patient needs. It's a quite fascinating ventilation model. And to create such machines, then, what do we have to, as engineers, deal with? It's non-extreme conditions. It's low speed gas, normal temperatures, but temperature matters, and pressure variation matters due to compressibility of the medium. It's a gas. There are many different gas components. It's not a pure gas, it's a mixture of them. Humidity, which can be a problem. Condensation even more. And we have a high dynamic flow range to deal with, because with one device, we try to cover the complete patient range from adults down to the premature patient. The flow is always transient, never steady. So we have to account for that or choose methods depending on that. There could be secretion and contamination, and we have some variation in the ambient conditions with if the ventilator is in Bolivia or if it's at the sea level. We should be able to be transported in the hospital and in some tough MR environment, magnetic resonance environment. So for the engineers, the challenges related to fluid mechanics, well, we have to consider pressure drops when you do plumbing, constructing the pipes and ducts. The device itself has to be ventilated because, well, you need to ensure good cooling, and also since we're working with oxygen, if there's a leak, it could be a very violent fire if we don't ventilate the device itself. Gas mixing, I mentioned. Since we're working with many gases, we want to have them mixed in a good way. But sometimes we want to avoid mixing as well, because perhaps we want to separate gases with a buffer region in between, and I will give you an example of that. So gas mixing is something to consider when you create these machines. Flow measurement is the other challenge, I would say, because it's always transient. You will have flow measurement always depend on the profile. So you have to use some flow conditioning. And we have this gas mixes with different components that affect the flow measurement. And the very basic question, the first question, where to measure? In the device or near the patient? Ideally, you would like to be near the patient, but that position at the airway opening is not very nice for a flow measurement, because it's a humid region with condensation and secretion. The flow is bidirectional. You have alternating in-spin exp gases with different compositions. You don't want to add a bulky device there, and you want to reduce dead space in the airways. So we go for a flow measurement in the device, or possibly both. You can have them both in sometimes. Mechanical design, then, this is an old version of a ventilator. You have to ventilate the electronic part of the device. From there, the flow should go into the pneumatic, where you could have some oxygen leakage. You don't want to have the flow go the other way. And we use a CAD system for this with an integrated flow analysis. And it's often an iterate procedure with simulations, testing, simulations, redesign testing, etc. When I joined the company 20 years ago, this was like a specialty competence, but now the mechanical design engineers can do it on their own. So it's at least 5 years ago since I did something of this, in fact. Another example with gas mixing air and oxygen to the left in some tight pipe construction with a flow sensor and a concentration sensor. You want them to be well mixed when they reach the sensor, and otherwise the sensor is not measuring something that's representative. And also you want the velocity to be reasonably well distributed and homogeneous before it reaches the flow sensor. So this is the type of simulation that we do. This is quite easy also to test in many different versions because of rapid prototyping these days. 3D printers, you can test 10 or 20 versions of the design quite easily. flow measurement then. So we, as I said, we go for internal flow sensor. In this case, up to the left, right here, we have mixing in a quite short distance, as we saw before, some sensor. And then on the expiratory side, we have, we use ultrasonic sensor because they are less dependent on the gas mixture. On the expiratory side, there's also always a mixture. On the inspiratory side, there is a flow sensor in each of the, for each gas. So then it's easier. Then we can use a simpler device like a pressure drop device. And then you have to account for the fact that we deliver a cool and dry gas, which expands in the lungs. So there you have a 10% expansion. So if you deliver 500 mils of cool and dry gas from the fresh gas side, it will expand to 550, 60 mils tidal volume. So you have to think, it's not rocket science, but you have to think about it anyway. And also on the way on the expiratory side, the gas cools down and a portion of it condensates again. So what you measure in the expiratory side is not exactly what was in the lung volumetrically. And the anesthesia machine is another example with a different, more complex internal structure. You have a ventilator that push gas into the system, and the gas goes out through the expiration valve. And then there's a circle here where you just add as much of medical gases, anesthetic vapors, laughing gas, and a good composition of air and oxygen in the proportion that is absorbed by the lungs. Ideally, the gas in the circle should never leave the circle because anesthetic gases are expensive and they are not very friendly to the environment. They are greenhouse gases. So it shouldn't look, in fact, the way it looks here, because here an exhalation would go out, follow the circle, and then go through the system. So instead, you need this buffer region that I was talking about. You need a buffer region here. Traditionally, it's a bellow in a bottle system, which gives a quite good limitation between the circle gas and ventilator gas. But we have gone for another solution, which is just a flow volume with as little mixing as possible. It gives better ventilation properties. So in fact, anesthesia machines were used as ICU ventilators in some early phases of the COVID during the springtime when there was a lack of ventilators. But not all anesthesia machine can do that. It's not, this construction with a bellow in the bottle is not so good for good ventilation properties. Okay, so that was about the machine, how we as engineers can design the machine, which we have full control over. But what about fluid mechanics in the lungs? The lung are as they are. We don't design the lungs, but what can we do anyway there on that side? Well, we can change the type of fluid that we are ventilating with. So, for example, if the ventilator delivers helium and oxygen instead of nitrogen and oxygen, you will get a lower density, have a tendency to more laminar flow, and also increased molecular diffusion. So there are a number of good effects of using heliox instead of air and oxygen. And the geometry, you can influence the geometry of the lung. You can play around with positive pressure levels to open up more or less of the lung. You can administer bronchodilators if you have a problem with asthma, things like that. You can also administer vasodilators, which will open up the or facilitate the perfusion of the lung. So you do that by, for example, using nitric oxide. in low concentrations, 20 ppm or something like that. And also you can play around with the position of the patient because it matters. Gravity matters in this case, since the lung is a porous, spongy thing. And it turns out that the prone position, like in the image here, tend to improve the VQ match, match of ventilation and perfusion in the lung. So it could be good from that point of view. And you can choose a completely different way of ventilating, flow type. If you go to high frequency oscillation, it's very small volumes, but you more vibrate the gas in the lung, and it's like an augmented, enhanced diffusion that does the work there. So you can do things to the lung as well that is related to fluid mechanics. And my final slide then, which is in fact about nebulizer. So we support the use of a nebulizer with the ventilator. So it's a nebulizer that we get from a company called Aerogin, and we can control it from the ventilator. It's a micropump technology. It's a vibrating mesh, very high frequency vibration that generates an average droplet diameter of about 3 micrometers. And I don't know, I haven't worked with this myself because it's the product is there. We're just incorporating it with a ventilator device. But as far as I understand, if you manage to keep a low laminar flow profile using, for example, helium, that could improve the delivery of aerosol into the parts of the lung that where you need it. So you get less deposition in the upper airways and it reaches further down. Maybe someone can confirm that, but this is not my field of expertise. So that's all from me. Thank you.
Thank you so much. Very interesting. I have we'll take one question here. So how do you see the evolution of the mechanical ventilators in the 10, 20 years? What would be the most challenging from a fluid dynamical perspective?
Yeah, I tried to think about that. I don't know really. I mean, if you look at the trends now, it's more, the trend is more like going in the direction of integrating different devices. Integrating information from a ventilator with a monitor system and things like that. So we don't see much happening on the fluid mechanics side of it. It seems as if the devices are quite mature in that sense right now. So it's more going to collecting and combining information from different sources into decision support systems, I think, and make the ventilators even more easy to use. But we don't see much development or visions on the fluid mechanics side, in fact.
So it's more on the machine learning.
Yeah,
yeah,
exactly.
Okay. Thank you so much again. With that, I would like to introduce our last speaker for this session. Last
Can you see it?
No.
No. Okay, then I have to go out again. Can you see anything now?
Yes.
Is it okay? Good. So I talk about fluid mechanical aspects of drug administration by inhalation, and you have heard that already today, this morning, yesterday too. But I'm going to pick, since I guessed that it will be already covered in one way or another, So I picked up a few items that I believe could be give some better insight in some aspect of this of the problem of drug administration and the fluid mechanics of that. So in principle, what you want is the right drug, right concentration, right place, and the right time. So any error in any of these is meaningless. Makes the whole thing meaningless. And the drug can be anything: gas, droplets, and particles. The gas is NO, for example, or anesthetic agent. And this is not a new thing. It has been around. Anesthetic gas agents have been around for 170 plus years. And nitrous oxides, for example, are being used since 1844. And in the lower part, the yellow marked are anesthetic gases that are used currently in operation rooms. And so this is not a new problem, but the problem is still here. And it gives you a flavor of understanding that it's not easy. Okay, and I try to explain at least why it's not so easy. You have seen already these pictures of the nebulizers and the way of administrating particles. I'll come back to one of these at least. But the more interesting is that when you try to see what is coming out from these apparatus. Here are 30 apparatus that are being. Can you see, by the way, the whole picture, Lisa? Okay. There are 30 different apparatus which generates nebulizers, and you have 3 different segments of particle sizes or droplet sizes, less than 3 microns. Okay, I just have to go back. Those are between 3 and 5 microns, and those are the shaded area, which is between 5 and 8 microns. And in this axis, you have the dosage delivered in percentage. So as you can see, some of them delivering altogether 30%, the others are delivering much more. But if you look at the small side that can enter to the airways, is varying between something like a couple of percents to maybe 10, maybe. If you look in the other way, another picture, which is roughly the same, telling you after 5 minutes of nebulization, how much percentage is going to the patient. So the black one is 5 minutes, and the white is the white is the 5 minutes, and the black is altogether when everything is nebulized. Is again a large distribution. So it means that it's very difficult to quantitatively give real numbers what is being delivered to the patient. Now what's coming into the patient, and there are 3 main challenges. The one is the transport in the airway, transport near the walls, and transport through the walls. I talk mainly on the first, well, mainly the second, but I mentioned the first also. And we shall see if I can say something about the third one. So this picture you have seen. So this is a classical picture. You have the extra thoracical area, and then you have the different branches. The main interesting point that I have this, because you have seen it at least 3-4 times, is that the area increase of the total area of the bronchial tree is exponential, and it's quadratic as going through the branches. So this is a logarithmic scale, semi-logarithmic scale, when you have the number of branches and you have the power 2 of this branch gives you the sectional area. And that is an impact because larger sectional area, you may think that you get more surface area to absorb the drug. Well, that's what you may think. Now let's look at models. The conceptual model that usually is that you find in the literature and mainly among journalists is what I call zeroed order. That is, what you inhale is going down, and then when you exhale, it goes out. So it's very close to the Swedish labor market, because what you inhale first comes out last. So like, you know, when you have a job, if you get into the job first, you get kicked out last. And this is what happens here too. And it's very important to remember that, because if you want to give a drug that goes to the lower parts, you should give it in the beginning, not in the end of the inhalation. In the end of the inhalation, they are just being captured in this area, in the upper part. There's no meaning at all. The other part is why this is a not so successful model is that because there's fluid mechanics and there are a lot of areas where things are being captured. A first order model is this called trumpet model, where it's utilizing the fact that we had a quadratic behavior or area increase when you go across this bronchial tree. This is why the area is increasing quadratically. And then it includes the basic physics. So the time rate of change of the concentration, in this case for the CO2, is proportional to the convection. This is the first term. Diffusion, this is the second term. And then sources and sinks, that is what's coming in and coming out by different processes, which are not given explicitly. If we go to the next slide, just gives you numbers. These are particular, the calibration, calibrated by experiment, this kind of a model. This is a first order model. Now, is the first model order model is good enough? Well, the answer is, well, you have to look a little bit more in detail. Now, let's look at a practical example where this model has been used. This is the not only the CO concentration as function of the exhaled flow rate, but also NO, which is a very potent drug and also very toxic. Because once the NO is when it's being coupled to the hemoglobin, it gives you methemoglobin, which blocks the oxygen from being coupled to the hemoglobin. It's like CO by itself. And the second thing is that it's being converted to in humid air into NO2. Or a nitric acid in practice, and the conversion, the half time for conversion is minutes. So if you capture NO in some pocket, it will be converted. So it's, you see here when you have an exhale flow rate is some hundreds of milliliters per second, you get an exhaled NO, and it's in very small parts per billion. But still, you have, it's not going to zero. It is still there, and if it remains there, it will be toxic for the lung. This picture, as you have also seen, and this is also a model. It was described. It describes where particles of different sizes are being captured, and this is wrong, because the model is based on the fact that at least for the bronchi and is correct more or less. And for the extrathoracal, that is the upper part of the airway, is probably correct. But it's wrong with respect to alveoli, because it was based on the assumption that small particles are being, because the Stokes number is small, they are traveling back and forth together with the air. This is the zero order model, which is not so. If you look more closely, what's happening, and that's what we are trying to do now. Just before going that, let's look at because we are not looking at straight pipe, but you have curved pipe, and they have secondary flow, and which depends on on the band size. But you have also several separation bubbles in different places. And what's more, you can get, and when you have separation bubbles, if this is a experiment showing the concentration of a marker as it goes through a bent branch in a branching pipe, and you would expect as the zero or model saying you that if your flow is going like this through the branch one, it will just go simply through it. It is not like that, because it goes through down first and comes back. You get very curved streamlines or behavior. And if you look closely, even more looking at different as the impact of the diffusivity, mass diffusivity, in this case it's low mass diffusivity, you get different behavior depending on the conditions that you have in the upstream situation. And if you compare two drugs, with one is with low mass diffusivity, this Schmidt number 2, or with high mass diffusivity, low mass diffusivity, high Schmidt number, and high mass diffusivity, the low one, you have a difference between the two. This is the difference between the two, and you can see that this behavior of passing through the branch and coming back is very dominant also in this case. Another interesting thing happens when you have multiple bonds. You get a swirling flow, and in fact it's used in the this apparatus, which is inhaler, turbohaler. You had a swirl generator in order to avoid the droplets or the particles that you inhale hitting the back side of your mouth, and instead, when you have a swirling flow, it will go with the flow into the trachea. Now let's move. Just mention that was so. In the real trachea or airways, you don't see the pipe flow, the classical pipe flow, but you have a lot of vortices. What is the meaning or the implication of vortices, of these vortices, on the motion of particles or droplets? And that's why I just made a short sketch of the forces that act on a particle and droplet. You have a drag force. You have external force depending on the charges, or it may be depending on the pH, for example. You have centrifugal force when you have a density difference between the particle and the droplet and the air, and depending on the curvature. And that's why I showed you the curvature, that you have strong curvature as you have small, tiny bifurcations from different branches. You have gravitational force. You have the near wall effects. You can have a Subman force, which gives you a lift away from the wall, or a Magnus effect, depending on the rotation, which may give you a force towards the wall. So the wall is playing an essential role. And that's why I want to talk a little bit about mass transport near the wall, not through the wall, but near the wall. And this has been a little bit discussed by previously, I think both today and yesterday. So in fact, the airways are covered by a layer, which is called the airway surface layer. It has cells, which, let's say, this is a nicer picture, and as it was shown, it has a very different functions, but the morphology is that you have a cell layer with cilia on it, and there's liquid in between between these hairy cilia. Above that, you have a gel, which is mucus, and more importantly, that this is not a static picture, but it is moving, and you can see that the impact of that layer. When people have been looking at the cystic fibrosis disease and the impact of the disease, or the interaction between disease and the layer, you have a decrease in the chlorions and bicarbonate ions, leading to change in salt and pH concentration. You have a decrease in oxygen content, and you have a decrease in the volume, and altogether you get, which leads to the clinical impact. And so once you know what happens when you have a disease, and it may happen also under normal situation, depending what kind of drugs you take. So if you go a little bit look more closely, what people have been found out, that you have a ciliary layer, which is about the upper part of the airway, 7 micrometers, and the gel thickness of 10 to 50 micrometers, and a flow speed of 6 micrometers per second. You think it's very low speed, and it has a function of transporting bacteria, whatever it has, up to the upper part of your throat, and then it's being swallowed mostly, and goes to the stomach, where it's being disinfected by the acid environment. But if you compare, you have a particle of, say, 6 micrometers. So if you think that this 6 micrometers per second is slow, remember that if you have a particle of 6 micrometers, it means 10 times the diameter in 1 second. It's an enormous speed. Compare it to a car of 4 meters. It would compare to a car driving at 40 meters per second. It's enormous speed. It's 150 kilometers per hour. So this layer has a very important effect or impact on the motion of particles nearby. That's only one aspect. It's the speed of the Yale itself, but it has also other issues, because if you look at the Yale thickness, or the thickness, it's varying as you go through the branches, and the I'll go to the next picture because it's more interesting. If you look at the physical properties of this Yale, the viscosity is varying depending. It's order of, say, in this case, order 10 Pascal second, and the modulus is order, again, varying very much. The ratio, if you have also a shear layer, you can define a dimensionless number. And if you look at different, which is important, I'll come back to that in a minute, the physical properties of this mucous layer is very much changes. If you have bronchitis, if you have a chronic, mild chronic, severe, you have the viscosity changed by a factor of 2, but the modulus changes by order of magnitude. And if you go further down, you can see cystic fibrosis, as I mentioned already. Different measurements give different numbers, but still you have a large variation in the physical parameters. So what's the impact of that? And the impact is very simple, because if you have this, for a simplified pipe, we have this mucous layer. We have what's called that's initially symmetric, axisymmetric. You have a possibility of developing what's called Rayleigh plateau instability, and initially it's axisymmetric, but later stages becoming non-symmetric. I'll show in a minute what is the meaning of this Rayleigh plateau instability. And it is, if you have a pipe with a layer of H0 and the diameter radius of A, so suppose you have a long wave pressure variation of a long wave, like the one is, or short wave first. So suppose you increase the pressure, and if you have a short wave, so you cannot, or you have negative, you try to have negative pressure, you cannot, because there is a negative pressure, it's going to be the perturbation is going to disappear, and if the perturbation disappears, it's corresponding to a stable situation. On the other hand, when you have a very long wave situation, then make a perturbation like in this picture, then it can suck this layer further up without being interference from neighbors. So, and that's, you can show more, not only by handshaking, but more systematically, it's unstable. So this is an unstable situation. And that's what happens in this case, that you get this instability, and which closes the airway. So you have this mucous layer may fluid mechanically give you a blockage. Another aspect that happens, interesting thing happens, if you have a particle, this is your mucous layer, with the modulus G, for example, as we had, and the viscosity, which was eta. So if this particle is moving in that direction, due to this impact between the interaction between the two particle and this layer, you get a lift force on the particle. This lift force means that the particle, which is a drug, was supposed to enter this layer. It won't do it. It's being moved away. So it's very important to remember that the physical properties of this layer, which is depending very much on the disease that you have and the drugs that you give, affect also the absorption. So it's a very non-linear process. Now, just jumping over to the alveoli, just wanted to show that what kind of sizes do we have. It wasn't mentioned in previous talk, that you have a layer membrane of about 2 microns that separates between the air and the vessel or other cells. And this, there are different models for that. It's membrane, usually it's membrane-based models. But to summarize the impact, the relationship between two major factors. Perfusion is the blood flow that you have, that is how much blood is traveling through this alveoli, and the diffusion is, for this case, oxygen and carbon dioxide, is determining how much is the exchange between the air and the blood. And this picture is a nice picture showing you how long is the blood, the red blood cells flow through it. This is through this capillary. It takes something less than 1 second before it's being completely oxygenated. Or that is, you have the oxygen saturation 100%. But now you have just a schematic picture of different situations that was discussed also this morning. In a normal situation, you have a normal alveoli with a normal capillary, so the blood is being oxygenated, you get red. But you may have different other situations. For example, when you have a collapse atelectasis of this alveoli for different reasons, can be different reasons. And of course, there's no, if you have less air, you have less contact and less diffusion. You may have another situation where you have a fibrosis of the surrounding of the sac itself, the alveolar sac. Of course, a thicker layer to penetrate. If you have a pneumonia, you may have fluid inside, or the same situation when you have edema, and or you have an external edema. In all these situations, you have, in this case, you have less air, and you have, in this case, you have a more thicker layer or membrane to go through. And finally, this emphysema, which is means the collapse of the alveoli are not, the area very simply is much less than it used to be. And therefore, the less area, the slower the diffusion. So, summary, or what is the idea, what the main idea, message that I wanted to give is the importance of non-uniformities and this airway surface layer, and their role in drug administration. And I didn't touch any of these other important things. This is a biomechanical reaction and nanoparticle behavior in airflow. That's when you go to small particles of nanoparticles, you get drag corrections or Cunningham declaration instead. Casimir forces, which are due to quantum mechanical aspects, and so on. Just my own reflection of this issue of drug administration by inhalation. This is multidisciplinary, multi-scale, multi-complexity, and you have to have fluid mechanics, of course, to handle different phases, different sizes. You need the chemistry, which I didn't say anything about, but we have been looking at the NO chemistry, for example, and total side effects, which are local side effects, which are due to the drug, it's medicine. And We started 1844 with the nitrous oxide, and it's a very long way to go before we are going to be able to make a good drug administration through inhalation. Thank you.
Thank you,
Thank you,
Laszlo.
Laszlo.
So now we have Laszlo,
Laszlo,
you can put it on temporarily because now my echo is it's but I think you made a good bridge into the discussion later on, because there was a lot of different questions here, which we still a long way to go, as you said. Do you think we'll take another 140 years or 50 years to solve it?
No. We have an exponential growth, no? And yes.
I was thinking, because now we're a little bit, so we should go into the panel discussion. Before that, I would like to, I think we should suggest that we should take a 5 minutes leg stretch and then come back here. 11.
I'm not sharing anymore, okay?
Yes.
I take away.
11:16. Just to give you, according to my watch here, and then we'll have 40 minutes discussion.
Let's. I'm going to suggest we have a 3-minute leg break. So we're here back at 11:15, and while we have the break, I want to announce that yesterday's video is already in YouTube, and I have posted the links directly to the video, and also the link. The video is linked from the webpage where we announced the event. So if some of you already have mentioned that you would like to have the videos. So it's there. It's about 4 hours, and YouTube was kind enough to not complain. It's all there. So let's take a stretch.
YouTube did crash last night, Mario. Was that you?
I wonder.
Right, I'm looking forward to the panel discussions in about a couple of minutes.
So, let's see if we are all back. And just to start off, I should start off by thanking all the speakers in the morning sessions. And I hope I hope you all appreciate or enjoyed it as much as I did. I found it very interesting and raised a lot of questions. So thank you so much. And now we're heading into this panel discussions. Let's see. We had some questions from yesterday, which we did not, we were not able to, well, we did not have time to answer. So we're going to start with addressing those.
Yes, and also we do have to take into account the panelists that are able to be here today.
Yes. So.
There have been several discussions and several questions regarding the humidity, and that was a very interesting question, and that was posed online on increasing the humidity in indoor air, and how efficient is this to prevent spreading, for example. And I think that maybe all the panelists can think of initiating a discussion along this line, how increasing the humidity in indoor air can affect the virus spreading.
May I say something?
Yes, of course.
Yes, so I think it at first this was really mysterious, the effect of humidity, because you could think that if the air is more humid, then the large droplets will survive longer. The droplets will survive longer, and that should be bad because you would have more droplets, right? But this now we sort of understand that this thinking is mistaken. If there is more humidity, the large droplets stay large longer, and since they stay large, they will be able to fall down quickly for a longer time. They will have an ability to fall down which will last longer. So you will remove the large droplets, the initially large droplets, I should say, and droplets that are at time zero large will be removed from the pack faster. And so on the opposite, if you keep these droplets in the cloud, then you have this cloud which is on top of the room, for example, which is more populated, which is has a larger number of basically of COVID samples, of copies of the virus. So I think in the end, it's more dangerous because this cloud will eventually fall. The droplets sediment at various rates, so they disperse by turbulence. So this cloud, which is over your head, will fall, and then you will get sick unless you have efficient ventilation. But that is not always the case. So I think it explains the negative, rather the positive effect of humidity. It removes the big droplets.
I think it should be clear about what mean large and small, because if you look at droplets which are tens of micrometers are really not, they are not, I don't think they are issue. They have to go into your nose or your mouth, inhale directly. And if you go to nose, you have a very good filter in the nose. Unless it's being, if I recall, I read somewhere that it being attached to the, it can penetrate cells the lower parts of the respiratory system, not in the upper part. Apostolos, maybe you know better. No.
Apostle.
Oh, maybe Ruggero.
If I can add something, I think that's not completely true. As a matter of fact, there are some paper that has been published demonstrating that we have specific receptor in the nose, and the nose is the most likely gateway for the virus. So it is not necessary that you inhale in the deep lung the virus. And in this respect, the dimension, I agree with you. We need to figure out what we mean with large and small particle or droplets. But with my experience, particle in the range between 10 and 200 micrometers efficiently impact and deposit on the nasal mucosa. And so we have quite a broad range of dimension to look at. If we look, of course, at the droplets in which the virus can survive. Yesterday, there was some presentation introducing a concept that it was completely unknown to me, which is related to the biology of the virus, indicating that likely the virus prefer to stay, let's say some protein related to the virus survival prefer to stay in a very dry environment instead of a liquid environment. As I said, it's something very new to me. I'm not a biologist, and I'm a pharmacist by training, so I don't want to say anything which is not strictly related to my direct experience. But that's something that we have to consider. If it is so, that's something that we have to consider. Coming back to the Stefan consideration, I agree with you. The increasing humidity may result in an increase of survival of big droplets that eventually will fall and then will not be available for being inhaled. But perhaps the most dangerous are the very small one. Those that in normal, let's say in normal condition, so when you have high temperature and low humidity, will immediately evaporate and therefore will not be longer available for being transported and inhaled, will survive probably longer.
You said they will no longer be available? I'm sorry, I did not understand that. I didn't understand the words.
Yes. I said that if the droplets, the very small droplets, let's say 1 micron, 2 micron, or even lower dimension, are in a very dry environment, they will likely evaporate very rapidly because they have a large surface area. And
yes, I agree they will evaporate. But what happens after they evaporate, this can be two things. Either you have perfectly pure water, which is very unlikely, and all you keep is the virus, but the virus is still there. It does not mind being dry. The virus is protected by a layer of lipids, if I understand it. It doesn't mind being dry. And yeah, so you can still inhale it. The second thing is, if the saliva is not pure water, there is a non-volatile component. If the non-volatile component is 12.5% in volume or mass, I don't make the difference, then the final radius will be only half of the initial radius because it's 1/8, right? So it's likely that as the droplets evaporate in very dry air, they just shift their size. So you have a whole distribution of droplet sizes. And I think to answer Laszlo's comment, we should think in terms of spectra of droplet size, not given droplet sizes. So a whole spectrum of droplet sizes shifts a little bit to the left. I mean, with the zoom mirror function, I'm not sure whether I should do this or that, but it should shift to the left. And then you just get a different population, but it's still a dangerous population of droplets.
I agree with you with the description of the fact that you get solid particles instead of liquid droplets by evaporation. The point is how much the key protein necessary for the survival and the capability of the virus to enter the cells will survive in a dry situation, which is something that I don't know. I think nobody has yet an answer for that. In my experience, we know very well that protein we prepare powder for inhalation, and we use also biologicals, and so proteins and complex structures. And we know that typically by evaporation, you get a denaturation of the protein with the loss of capability to maintain the biological activity. Well, again, that's something that I don't know personally, because I haven't read anything concerning the survival of the virus in a very dry environment. That's, I think, something that deserves more research and more deep investigation.
And from the fluid mechanical point of view, we can say things about how rapidly the droplets fall and how rapidly they disperse with turbulence. That's all we can say as fluid mechanicists. And then we have obviously questions that are transferred to the biologists or the epidemiologists or
how concerned shall we be about this? We are fluid mechanics experts, right? You walk on the street, you see people smoking 20 meters away from you, and you feel you get the sense of the smoke. So how concerned shall we be actually about this aerosol transfer from fluid mechanics standpoint of view? Please, Stefan.
This is an analogy I tell to my friends and to my students. Imagine what a COVID patient exhales is a poison gas, like World War I. In Sweden, you did not have World War I, so it was not a holiday for you yesterday, but for us, it was a holiday. Lots of people received poison gas during the war. If you are told that what the guy is breathing is poison gas for you, you take precautions, even if he's 10 meters away, right? And I think people do not really take the full measure of an invisible threat that is present in these aerosols. And that's a psychological remark, not a fluid mechanical remark, sorry.
Michael, may I make a step ahead on starting from this point? I would like to come back to a question that I posed yesterday to Staffan, which is related to this point. I mean, the capability, you need to adopt precaution, and for instance, the most important one is to wear a face mask. So yesterday, I posed a question to Staffan. I don't know if Staffan is here today.
No, unfortunately he had to leave.
Ah, he did. Anyhow, that's something they may be discussed all together. I asked to Staffan if they will take care, they will consider also the decay of the efficiency of the mask during time. One point that came to my mind is probably the question was not correct. In fact, the mask is a filter, and probably the efficiency increases with time, not the opposite. What do you think?
Sorry, I'm talking all the time, but I want to mention that my colleague, Christophe Josserand, is working on the fluid mechanics of masks right now. And he will giving a talk in the so-called companion workshop that will be tomorrow in Lyon. It's an Aircraft TAC workshop. Some of you may have received the information. So he will give a long talk tomorrow about this. I mean, he works on masks, so I hope he will also be talking about masks. I don't see what else he could be talking about. And then if you have time, you should participate in that Aircraft TAC meeting and listen and ask him the question. Because what he says, his model is that the mask is like a porous medium, right? And so his model, you have a flow through the mask, but you also have flow through the sides. And how much of the flow goes through the mask and the flow goes through the sides is a hydraulic problem, because you have a resistance here and a resistance there. So you just solve an elementary hydraulic circuit problem, and you know how much goes to the mask and how much goes to the sides. And if the mask becomes too impermeable, if the conductance of the mask drops, then things go to the side.
That's a good point, but you have to see the situation from the opposite. The mask is for protecting the other people from you, but protects you from the other people. So the efficiency should be seen also from in this respect. If it is a filter, probably the efficiency for protecting the people, the person wearing the mask, would increase during time. The opposite would be for protecting the other people.
Yes, well, it's complicated because also what happens if you put your hands on your mask, then you have these particles that were trapped on your mask, they go on your hands. What happens next?
That's another point.
You pick your nose, that's fatal.
Yeah, that's another point, correct.
We have a question that is related to what you're discussing from Anders Dahlkild. What do you think is the main positive effect of an ordinary simple face mask? To diffuse the exhaled air jet or to collect droplets in both ways of breathing?
Question is for who? For everybody.
Well, I think it's for you, Rogero and Stefan, since both of you are talking about face masks.
Okay, I will say something. There's a huge issue here about sneezing. Okay, obviously, if you wear a mask, it will tremendously reduce the effect of sneezing and even of coughing. But we don't know, and there was a discussion yesterday, we don't know whether the disease is propagated by some super spreaders who will be both very rich with the virus and have a more usual type of common cold and sneeze a lot, or whether the virus is propagated by people who talk. If sneezing is really a concern, then the mask, by blocking the jet, has a huge effect. If sneezing is not a concern, then maybe for talking, it's maybe less of an issue.
Well, we are doing some experiment nowadays because we are carrying out a project in collaboration with the School of Music here in Parma. You know, Parma is a very famous city for music, and that's why we are also involved in this measurement. And what we are doing is measuring the amount of droplets emitted by the voice during singing, and by the instrument like flute and or things like that. And what we see is that if even in the case of simple talking and singing, you have quite a lot of emission. Yesterday, somebody shows some data in this respect. I think it was Jacob, if I remember correctly. So the mechanical aspect is the most important. The mechanical barrier, I mean, is the most important one. And this depends upon also what type of mask you are considering. Because again, you have to take into consideration that you have to avoid the people around you to get in contact with your droplets, the droplet that comes from your respiratory tree. But at the other end, you must be sure that you protect yourself from the droplet that may be around. And according to what I have seen in the research, they stay around, they can be there for a long time. Depending upon the environmental condition, the ventilation, and so on and so forth. But that's another point that has to be carefully taken into consideration.
We have another question, and it is about performing simulations. This is coming from Manash Borthak, and it is for performing simulations in lungs. What sort of outflow conditions can be, and I need to scroll down, can be imposed? So this is about the, I guess, the boundary conditions. And who is doing lung simulation? Who would like to answer these questions? I know yesterday we had a few people doing that. Perhaps we skip the question because I do think yesterday's panelists who would answer this question were not able to be here.
The boundary conditions are obviously exceptionally important, and that's why also this has been something that I asked directly Dr. De Backer yesterday from Fluida, I think the question is how much we can extract from reality and actually impose on the simulation side. And those are the real limitations. And maybe Magnus can comment on this since they have a similar challenge with respect to developing ventilators. Obvious thing is we talk about a transition. We talk about a fluid flow scenario which is transitional, and we talk about pulses, and we talk about a very complex geometry, and we talk about a lot of multiphysics. It's really difficult to have entire boundary conditions. We talk about compliance of the tissue and so on and so forth. So this is a real challenge indeed for our simulations today.
Apostolos.
Yes. Can you hear me now?
Yes.
Yep.
Yes, eventually. Thank you. No, this is what I want to add is that we have started now look something that it called tracheomalacia and extensive dynamic airway collapse. That means that as it is in many patients, that as is the trachea, the part is going more than 50% decrease when we exhale. And this is something that we start to look during the last year, and we find that in patients with asthma. And it's very, very variable. And this is something that I think it makes it more difficult because we see patients that they have nice spirometry or the same, but they have a great variation. And as the disease is a chronic disease, this is also something that we say, okay, today we have Mihai and Lisa, and next week, is it the same? So this is something that we need to include in the model somehow. And I don't know how easy is that, of course, and just to make it more complicated.
That's why I put in this point that you can show that if you have a certain properties of this surface layer, it can lead to collapse of or blockage of the airway. And that's why it's important that you take not only making analysis of CTs and things like that, but rather taking specimens from the airway, which you can do it very simply when you go with a laryngoscope, for example, and pick up some specimens, make a chemical analysis of that, and checking the properties of that sample. That gives you an idea, and maybe it's very simple just by improving reducing the modulus, and that you prevent the collapse of these airways. That is, and that's not very difficult to do, like a surfactant-like. It's not well. If you know the reason, at least you can handle it. If you don't know the reason, you cannot handle it.
Yeah, I understand. But have you done bronchoscopy? I done every week, but it's not easy for the patient, I can say.
Laszlo,
it's not easy with ECMO either.
The thing is that, can you hear me? Yeah, I totally agree. And you see that one part of this chronic patient, they have this problem with mucus, excessive thick mucus, and it's not easy at all to handle it. And it affects the patient, it affects the medication, as we have discussed, how to go in. And we work extremely We see many times it doesn't help to increase the medication or change. The best is to do a very intensive airway training with a physiotherapist, and the patient take maneuvers, the one that with the respirator that they did this recruiting. And it is thick, and many times the problem we have now is that also that there are microbia, but with the classical cultures that we do in everyday clinical practice, you don't get anything, then you have to go bronchoscopy, that we get something, not often. And then when you start to do this sexton RNA, this phylogenic analysis, we find huge amount of bacteria. And I think this is the time also that exactly as you say, but I totally agree with Lazaro. We do not, in our clinical use, we do not analyze how thick is the mucus, we just look it and say drink some more water. But inhaled of natrium chloride is also a therapeutic option that you use a lot in those patients. That's true.
On this, when it comes to the mucus, what I really got stuck with was actually the 60 micrometer per second velocity, and also thinking of what's been discussed regarding the different particle size. So we have an alveoli that's on 1 micron less, and then we can get particles that are about what was it, 2, 3, 4. So we're already on the particle size we're larger than where we want to reach. And then we also have the transport then of the mucus. So I've been like, how should we, from a modeling point of view, handle this? What would be Rogero?
Well, that's a quite interesting point that has been discussed for a long time, for considering the fact that you don't have, unfortunately, you can't simply deposit your formulation in the right side of the lung, because then it has to cross the mucus, it has to cross the epithelium, and it has to enter into the cell. Crossing the mucus is one of the most important and most challenging aspect that should be considered, especially for some specific pathologies such as cystic fibrosis, where the amount and the how to say, the viscosity of the mucus is so high. It is not only a matter of dimension, it is also a matter of charge of particles. Because you may have an interaction with the mucus chains, and the particle may be trapped by the chains and will never be capable to go through the mucus. A nanoparticle approach with the proper size and charge of the particle is probably the only one that you may adopt. And after demonstrating the capability of this particle to pass, you will be able to make some model. But the problem is that nanoparticles are not easy to handle. It's very difficult to make a dosage form with nanoparticles unless you have a nanodispersion for nebulization. But for people like me that are preparing particles in solid forms, so powders, you cannot make a powder with nanoparticles as such. You need to transport the nanoparticle in microparticle that can be dosed and then aerosolized and so on and so forth. And then eventually the microparticle will regenerate the nanoparticle in contact with some fluids and some liquid in the lung.
Stefan, hold on.
I think I agree what you said, Ruggero. I just wanted to mention a fun fact, or maybe bordering on anecdote, is that the cuff machine I discussed in my talk yesterday was initially designed by Brock and Lundell to study the mucus in the respiratory airways, to study how the mucus would be pushed by cough. Normally the mucus moves because of ciliary motion, but coughing also helps move the mucus. So just a connection. I don't know whether it's of any significance.
Yeah, that's a point of interest. In some pathologies, as I was saying before, the mucus is so viscous and so much that it's even coughing. It's not enough to remove the mucus from the airway. Probably Apostolos has to say.
Apostolos, yeah.
It is like that. It's a big problem because we have patients that they are coughing like crazy, and the majority is that it's like stuck there. It cannot move it. So if you go to this patient with bronchoscopy, you see that is the airways, and there is a line like 1 centimeter that is all over. You cannot go through. It's like you are in the metro and you try to go within. It's terrible. One question, a silly question for you, everybody, but viscosity, is it something easy to measure? I'm thinking like in the near future, because if we have the patient, now I can order microbia, whatever test. Is it easy to take it and make a viscosity in 10 minutes? 10 minutes or 1 hour, and consider that?
It's very simple. I think they have some possibility in the chemistry lab because they have this kind of cone viscosimeters. So it's not.
Okay, thank you.
You can ask. I can check also. Who has it?
Only viscous.
No, Stefan, I think you can.
Stefan, please.
I mean, the fluid is not only viscous, it's viscoelastic. So you need to measure the two coefficients, the G and G prime and G double prime, the viscous and elasticity coefficient, which a rheometer will do.
Okay. I don't know. I'm just thinking if we are going to this clinical or something that can be valuable in the future, because now what we do in the past is to say, okay, do you cough? Do you have mucus? Yes, we see the color because this is and how big, and this is clinical. It's good clinical correlation, and but we don't measure. Okay, we see that is thick, but we don't have any numbers or something to measure, perhaps to evaluate the treatment or adjust the treatment, more personalized, that use this particle or those particles if the viscosity is, or the other that you say above 10, I don't know, in the upper level. It could be something, and I haven't seen any studies on that, or perhaps I have missed them. I'm not familiar anyway.
There are some projects active now at KTH along that direction, and I think also at KTH engineering mechanics we have been discussing for a while to actually have our own Burrow also rheometer. So that's maybe Lisa can comment more on this, but there are such possibilities to do such measurements.
We have another question, and it is for Apostolos. It is from Marco Crialesi Esposito. Dr. Bosios, is there a significant dispersion in mucus composition and density depending on the pathology? And we have been talking about this, but yes, perhaps we can go deeper.
There is this one, and you wait now. If I can find something, if it is in the cells, when we see the mucus, you see how thick it is, and also there is, just to find out something to share, if it is a lot of infection, even if we cannot find bacteria, we are measuring elastase. That is the activation marker enzyme that neutrophil is going out. So in the clinical, we use very well that patient that they have mucus that is green, very thick. They, even if you cannot find bacteria, they are there, and they have effect of the treatment. It's the marker of the elastase, neutrophil elastase. If I just can find the picture.
I can show a table with different diseases and the viscosity. Anybody interested, I can put it on.
Please.
Okay.
Rogero,
May I change I have a question for Magnus, if it is still there. Is that Magnus?
no, I think Laszlo now is showing the viscosity on different diseases. So
Right, but we need to ask him to unmute. Laszlo?
Well, here it is. Oh, sorry. Here it is. You have viscosity. It's in terms of times. This is 10,000 times more viscous than the water, and the first one, just for example, that. And it varies between different situations. So you have different measurements. So you have a lot of references. If you look at the bottom, you see the reference, so you can look it up. Okay.
thank you. Rogero, you had a question for Magnus.
Yes, it concerns the nebulizer. You talk about the fact that you are coupling your machine with nebulizer. The nebulizer is an adaptive nebulizer. I mean, the one that regulates the efflux and influx with the movement of the pump, or it's a normal nebulizer?
What was the distinction between a normal and a unnormal nebulizer?
A normal, I mean the one that makes the continuous emission, whereas you know, nowadays we have also adaptive nebulizer that adapt the emission with the inspiration and the expiration of the
No, I think this is always on. It's a steady.
It's always on.
Yes.
So you have emission from the nebulizer even during the expiration phase.
Yes.
And have you ever tried to figure out or to measure if there is some condensation of the formulation into the tubing during the different phases?
I am not aware of that, but this is really not my field of expertise. So I don't know if anyone really knows it.
Because this comes back to the initial question concerning the effect of the humidity on dimension of the droplets. And in that case, we are in a very confined environment, and it would be probably easier to check and control the dimension of the droplets according to the relative humidity. But you have also another variable here, which is the pressure of the system, because you change the pressure during the operation, and that would be something very interesting to investigate.
Yes, I agree, but as I said, this is really not my field of expertise.
No problem.
Sorry.
I actually have a question, Apostolos, that you mentioned it quickly in your talk that you when it came to asthma, there was a difference between females and male, and that also the asthma has some. Did I understand it correct? Like a protection, or acted more as a protection when it came to the COVID, or
not the asthma,
not the asthma, but
the inhaled steroids.
Yes, yeah, sorry, yeah.
It is a big issue that start now to look about sex difference, but it seems that women have more severe asthma, more symptoms than the men, and there are different reasons. In the children, it is more boys that they have and more difficult asthma or more symptoms, and then in the adolescents they change. One thing they believe, and it's getting more and more, and in the middle age, women is dominated to the severity. And one thing is that the geometry, because the boys have less smaller airways. as far. So the girls are developed faster, but then when they start now, when you are adults, I have more bigger lungs than you, for example. This is the one. But then it's also hormonal, and this is a very intensive area of research because it has been neglected. And it is very different. Some women, they have, for example, when they can menstrual, when they get pregnancy, and third get better, and third get worse. Then the menopause is totally different. So this is something of great interesting, but it is like that.
Yeah, and then like you said in the beginning, because now the fluid analysis then kicks in, but that if you have, when it came to smaller sizes, then I guess it goes for all, all the parts of the lung, right? Even to the alveoli. And then if we have problems not providing the small the small size of the drug that we want to deposit, then that's an issue as well that needs to be addressed.
That's true.
Yeah.
But this is totally true in our clinical practice, because here we have this center that from the whole region, Stockholm, when they have asthma that is really uncontrolled, we are the last, they send it to us and we have resources for that. So it is the classical that we get patients that they have come to this level, that they have small airway inflammation and it is closed. So the classical medicine with pulver doesn't work anymore. And they get huge amount, like 5, 6, 8 times, and this doesn't work a lot. They get also only side effects, and then we have to go to the small particles to help. What can be interesting is that I think that we should go early. We should go early. I think that we should start to be more preventive. Okay, so I believe that the classical aspect, when it starts, we should go with our best treatment in the beginning, because we down-regulate the inflammation, we keep it open, and then we can deliver the simple or the classical treatment. But it costs, we don't have resources, so I don't know, it's not easy.
Yeah, no, it just struck me when we were talking, like when you were describing this, and then also came into later on with the different sizes and velocities and everything that we have acting that we need to relate to in order to actually get the drugs where we want them. So, yeah. I think, Mario, you said you had an announcement in the chat. But you're on mute.
And now I am not muted anymore. Thank you so much. I would like to say thank you first. I know all of us are going to say thank you again, but thank you so much to all the invited speakers and panelists and all the participants. The discussions, the questions, and the presentations were wonderful. I learned a lot. I am sharing my screen and I have 2 windows of Chrome. On the right, I have the page that we use to announce the event. And as you can see here, I have already uploaded the video to YouTube, so you can go there to see yesterday's video, and today's video will take a few hours, but it'll be there hopefully before midnight tonight. I think we have created a wonderful documentation and record of the conversations and presentations we had. On the left, I have shared a Google document with some of the questions that were not answered. And Rajat in particular, he was very kind to go ahead and answer the questions, given that he was not going to be here. So if you were particularly interested in his presentation yesterday in the mathematical model of the likelihood of passing the virus from one person to another, he was pretty good in answering the questions and also including a number of links. So I recommend that you go there to check out Rajat's thoughts on the matter. And the final announcement I want to make is that if you go, if you want to link with the speakers, link with the panelists, or link with the participants, which you may have recognized, some of whom you may have recognized here in the list, I find that LinkedIn is a good way to link with people by sending a simple message. I enjoyed your talk during the workshop. sort of identifying yourself on why you would like to link with people. And I think it's a good way to keep the momentum going, because one of the purposes of today's and yesterday's workshop was to get people to talk to each other and get to know each other and find opportunities for future collaboration. Those were my announcements. Thank you so much. Now I mute myself and release my screen.
Thank you, Mario.
Thank you, everyone. Thank you. Thanks to the organizers, and congratulations for a very nice workshop.
Thank you so much for participating in all your interesting talks and the discussions. I truly enjoyed these 2 days. So
Thank
I'm
you,
very
Linda.
happy.
Thank you very much.
Thank you.
Take care.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye bye.
Thank you.
Thank you.
I will stop the recording now.